All right, welcome back everyone to another deep dive with Snazzy Surgeon, where we uncover those must-know bits from Bailey and Love.
Always a pleasure to be here.
Today we're going to tackle a topic that's, fundamental to what we do, investigating breast symptoms.
It really is the bread and butter, isn't
Oh,
it?
absolutely.
Yeah.
But even though we see this stuff day in and day out, the nuances can be tricky.
Oh, for sure. That's where experience and, a really solid systematic approach make all the difference.
Right, because at the end of the day, it's about getting the best possible outcomes for our patients.
Exactly. And that starts with a rigorous step-by-step approach
Yeah.
every single time. No cutting corners.
And speaking of starting points, we got to begin with the gold standard, the one we all learned way back when, the triple assessment.
The triple assessment. It's almost like a mantra, isn't it?
It really is. But it's more than just words. It's clinical examination, radiological imaging, and tissue sampling. When those three things come together, that's when we get the most accurate picture.
And it's not just that they're all important individually. It's the way they interact, how they inform each other. The data shows that the combined approach of the triple assessment gives us nearly 100% positive predictive value and diagnostic accuracy.
Wow, that's huge.
It really is. And it should really be the guiding principle behind every decision we make when we're working up a patient with breast concerns.
No question. So let's dig into the radiological imaging part of the triple assessment. We have a few different modalities at our disposal, each with its own strengths and weaknesses. Let's start with ultrasonography, or ultrasound as we often call it.
Ultrasound is a real game changer, especially when we're dealing with younger women who tend to have denser breast tissue. Mammograms can be harder to interpret in those cases, but ultrasound cuts right through that and gives us a clear view.
Yeah, it really helps us differentiate between those fluid-filled cysts and the solid masses.
Exactly. And that distinction is so crucial because it often dictates how we manage the patient. If it's a simple cyst, we might just observe it. If it's causing symptoms, we can aspirate it right there in the clinic.
Simple and effective.
And then we have those solid masses, those well-circumscribed mobile ones that feel like fibroadenomas. Our suspicion is usually low with those, and we might just reassure the patient and follow them with imaging. But of course, clinical judgment always comes first.
Of course, always taking the whole picture into account. Now, on the flip side, if we see a solid mass that's irregular, ill-defined on ultrasound, well, that raises our antennas a bit, doesn't it?
It certainly does. That's a red flag, and a biopsy is absolutely mandatory in those cases. We can't afford to take any chances.
Absolutely. And if we do end up with a diagnosis of breast cancer, then axillary ultrasound becomes critical.
Oh, absolutely. We need to assess those lymph nodes carefully, looking for anything suspicious that might need a biopsy. Nodal status is crucial for staging and treatment planning.
Couldn't agree more. Now, let's move on to mammography. It's still considered a frontline investigation, often used alongside ultrasound, especially when women come in with breast symptoms.
Right. And mammography remains a cornerstone of screening for asymptomatic women. We've got decades of data to support its effectiveness, especially in older women where the breast tissue isn't as dense.
Now, in terms of radiation exposure, we often get questions about that.
Yeah, it's a valid concern, but it's important to remember that the typical radiation dose for a mammogram is quite low, around 1 milligram per film.
Okay, that's good to know. And that's something we can use when we're having those conversations with our patients about risks and benefits, especially when it comes to screening.
Absolutely. It's all about informed decision-making. Now, mammography can also show us other signs that might point towards malignancy, like swollen lymph nodes, breast edema, or skin or nipple changes. But we have to keep in mind that those are often associated with more advanced disease.
That's an important point. So we shouldn't be relying on those signs alone.
Right. And it's crucial to emphasize that mammography by itself is not a diagnostic tool. If we see a lesion that's classified as BI-RADS 4 or 5, a biopsy is absolutely necessary to get that definitive diagnosis.
Now, speaking of BI-RADS, that's the language our radiologists use, and understanding those categories is so important for interpreting their reports and guiding our clinical decisions. It's how we communicate effectively as a team.
Absolutely. So let's break down those BI-RADS categories. A BI-RADS 0 means the assessment is incomplete. We need more information or we need to compare with previous images to make a judgment call.
Got it. What about categories 1 and 2?
Categories 1 and 2 are negative and benign findings, respectively. Both have essentially zero risk of malignancy. In those cases, we'd usually recommend routine annual screening for women over 40.
Makes sense. And then there's category 3, probably benign.
Right. Category 3 means the risk of malignancy is low, greater than 0%, but no more than 2%. We typically follow those with short-term imaging, usually at 6 months, just to be sure things are stable.
So watchful waiting for those.
Exactly. And then we get to category 4, where our level of suspicion starts to ramp up. This means there's a suspicious abnormality, and we need to seriously consider a biopsy. To help us fine-tune that decision, category 4 is further broken down into subcategories.
Okay, let's hear about those subcategories.
So category 4A is a low suspicion, with the probability of malignancy being greater than 2% but not more than 10%.
And then we have 4B, which is intermediate suspicion.
Right. With 4B, the risk is somewhere between greater than 10% and 50%.
And lastly, 4C, high suspicion.
Exactly. 4C means the likelihood of cancer is greater than 50% but less than 95%. So these subcategories really help us decide how aggressively we need to investigate, particularly whether or not to do a biopsy.
So those nuances within Category 4 can really make a difference in how we approach the patient. Now, what about Category 5?
Category 5 is highly suggestive of malignancy, with a risk of 95% or greater. At this point, we're talking about a biopsy or even going straight to surgical treatment, depending on the overall clinical picture.
And then finally, Category 6.
Category 6 is reserved for lesions where malignancy has already been confirmed by biopsy. This helps guide our management before definitive treatment, making sure everything aligns with the pathology findings.
So having a good grasp of the BI-RADS system is essential for clear communication with our radiology colleagues and, ultimately, for delivering the best care for our patients. All right, let's switch gears and talk about magnetic resonance imaging, or MRI, and its role in breast imaging.
MRI has become an incredibly powerful tool. It's particularly useful when we're faced with dense breasts or when the mammogram and ultrasound findings are unclear or just don't add up.
Right, it can help us see through the clutter, so to speak.
Exactly. And it's also invaluable for distinguishing scar tissue from cancer recurrence after breast conservation surgery. Sometimes those changes can look very similar on other imaging modalities, and MRI can really help us differentiate them.
That's a big one. So when those other imaging studies leave us scratching our heads, MRI can often provide the answers we need.
Precisely. And MRI is also excellent for assessing the extent of the disease. It's much better at identifying multifocal or multicentric disease, which has significant implications for surgical planning.
Absolutely. Finding those additional areas of involvement can really change our surgical approach.
No question. It also plays a key role in evaluating certain histological subtypes like invasive lobular carcinoma and ductal carcinoma in situ, or DCIS.
Right. Those can be tricky sometimes.
They can be. Now, MRI is also a crucial imaging modality for our high-risk patients, those with BRCA mutations, or a strong family history of breast cancer. It's often used as a supplemental screening tool in those individuals.
And it's often the preferred imaging modality for women with breast implants, where mammography and ultrasound can be limited.
Yeah, it's much better at visualizing the breast tissue in those cases.
And we can't forget about MRI-guided biopsy. It allows us to sample lesions that we can see on MRI but aren't visible with other imaging techniques.
That's a great point. It opens up a whole new avenue for getting those hard-to-reach lesions. All right, let's touch briefly on positron emission tomography, or PET, and its role in staging breast cancer.
So PE scanning isn't usually our first-line staging tool. It comes into play when we're dealing with more advanced disease like T3 or T4 tumors, or when there's evidence of N2 or N3 nodal involvement.
Right. It can also be considered in some T1 or T2 and 0 or N1 cases if there are signs or symptoms that suggest the cancer might have spread.
So it's really reserved for specific situations.
It is. And it's important to be aware of its limitations. False positives can happen. For example, in certain patient populations, inflammatory conditions, like those related to tuberculosis, can light up on a PET scan and make it look like there's cancer spread when there isn't.
That's really important to keep in mind, especially considering the anxiety a false positive can cause.
Absolutely. And we also have to consider the practicalities of cost and insurance coverage, which can sometimes limit access to PET scanning.
Right, those are real-world factors we have to take into account.
So while PET can be very helpful in certain staging scenarios, we have to use it wisely, considering its limitations and the individual patient situation. Now let's move on to the last piece of the triple assessment puzzle: tissue sampling techniques.
At the end of the day, getting that definitive diagnosis hinges on obtaining a good tissue sample for our pathologists.
Absolutely. And needle biopsy has really become the gold standard for initial tissue diagnosis. Core needle biopsy specifically is what we use most often.
And what gauge needles are we typically using?
We usually use a 14-gauge needle for breast lesions and an 18-gauge needle for sampling axillary lymph nodes.
Okay, good to know. And of course, these biopsies should always be done under local anesthesia and with image guidance, whether it's ultrasound, mammography, or MRI.
Of course, image guidance is critical. It ensures we're hitting the target accurately and getting the most representative sample possible. And from a technical standpoint, we always aim for the solid components of the lesion, avoiding any cystic areas or large blood vessels.
Right. Getting a clean, solid piece of tissue is key.
Exactly. Now, we also have vacuum-assisted biopsy, which has some distinct advantages in certain cases.
Like when?
Well, vacuum-assisted biopsy uses larger gauge needles, usually an 8 or 11 gauge, allowing us to retrieve a larger volume of tissue. This can be particularly helpful in reducing sampling error and improving diagnostic accuracy.
So we're getting more bang for our buck, so to speak.
In a way, yes, and it's especially useful when we're investigating microcalcifications on mammography because it lets us get a better sample of those tiny specks. And sometimes we can even use vacuum-assisted biopsy to completely remove benign lesions like fibroadenomas, which can potentially spare the patient a surgical excision.
So it can be both diagnostic and therapeutic.
Precisely. So we have a range of tissue sampling techniques at our disposal, each with its own strengths, and we choose the best one based on the clinical and radiological findings.
So when it comes to investigating breast symptoms, it really all boils down to a thoughtful and systematic application of the triple assessment. The clinical exam, the imaging, and the tissue sampling, each piece gives us vital information. And when we put it all together, we can arrive at an accurate diagnosis and develop the best treatment plan for our patients.
I couldn't have said it better myself. It's all about being thorough and using all the tools at our disposal to provide the best possible care.
Well said. We've covered the essentials of investigating breast symptoms, from the initial triple assessment to the nuances of various imaging modalities and tissue sampling techniques. Understanding these principles is absolutely fundamental to what we do as surgeons, and applying them consistently is what leads to the best outcomes for our patients.
It's been a great discussion. Thanks for having me.
Thank you for listening to our podcast. We'll see you in the next episode.